Next is Ross Williams. He is a PhD student in the Health Data Science group working at Erasmus in the Netherlands. His focus is on prediction modeling, specifically method development for model transportability assessment. He contributes to the Odyssey patient-level prediction workgroup and software package.
Great. So I'd like to start off by saying, firstly, thank you for having me along to talk today. I'm going to talk about predicting one-year risk of heart failure for patients with type 2 diabetes. So if you were listening to GenerReps this morning, you'll recognize the time at risk, the outcome, and the target that we're looking for. So why did we choose this problem? So firstly, it's a very clinically significant problem, because if you have type 2 diabetes and you get diagnosed with heart failure, you've got a 50% 5-year mortality rate. One of the other things that we also noticed is that in the guidelines, there are already recommendations. So for instance, I'm not even going to try and pronounce that, with TZDs, their use of caution is cautioned in high-risk patients. However, when we were doing a literature search, we were unable to find any viable prediction models for this problem. So if I say you caution when you're at high risk, but you have no way of saying that a patient is at high risk or not, there's not really an effective way to use this guideline. So clearly, we have a need for a well-calibrated, externally validated prediction model. Now, the problem definition. So if you've seen any of the PLP work, you'll have seen this diagram. So for us, our target population is what we call pharmaceutically treated diabetes. Our outcome is the heart failure, and our time at risk is for 1 year. So to dive a little bit more deeply into these cohorts, so we say pharmaceutically treated because we want our index date to be where we envision this model being used. And that's when, as a clinician, you're sat with a patient and you say that their diabetes has progressed to such a level that you need to make a pharmaceutical intervention. We're no longer going to try and do it with sort of lifestyle cures or lifestyle amendations. We're going to use a drug. And on the day that you make that drug, we want to say, what is the risk of you developing heart failure within 1 year? These cohort definitions are all available online at the link at the bottom. One thing to note is that we allowed people to have a diagnosis code up to 365 days after the event. This is just an artifact of how some of the data goes through the systems. For heart failure, so we just use a condition occurrence and an inpatient visit. However, in some of the databases we looked at, due to their nature, so for instance, the IPSI database in the Netherlands doesn't contain information on hospitalization. So we have 2 definitions of heart failure, one with the hospitalization and one without the hospitalization. Both of these are available at the links below if you want to find out more. Now, how do you do a patient-level prediction problem? If you want to do a patient-level prediction problem, your first step is look at this paper that's been written. This tells you everything that you need to do. It's the best practice that we have available. So how did we move from our clinical problem that we've set up into making this into a prediction exercise? So we developed multiple algorithms, including GBMs, Lasso, and Random Forest. I'm only going to talk about the gradient boosting machine results here because they were the best that we achieved. And then we used the following covariates for our model development. Now, we had 11 databases that were available for this. These span, I think, 6 countries and 4 continents. And as you can see, we've got quite a large number of patients, so 1.7 million, 2 million, and lots of outcomes. What we were really concerned with here is external validation. So our method of doing this was, in each of the databases, we'd develop a method, and then we would validate it in the other 10. So that's what you can see from the diagram at the top. And then what we did was we rotated the development databases. So you start in database 1, and then you validate in the other 10, and then you start in database 2, and you validate in the other 10, until eventually what you get is this diagram. And this is all the results. So to notice here, so we have the validation database along the x-axis, and the development database is along the y-axis. So if we move to look at the lead diagonal, what you'll see here is the internal validation scores. So if I select one of these squares, so this is this is the model developed in Optum Panther that we have then externally validated in the data that we have available in CCAE. And so the performance is great. And then any of these squares, you look to the left, you'll see the development database, and then you look down and you'll see what database it was validated in. The scale on this, so the red is 0.5 in area under receiver operating curve, which is basically a coin toss, and then 1, which is the bright green, is your best performing. So if we select the model that we think is the best performing, which is the Optum Panther one, you can see that we've got good to excellent performance. And not only that, but it's maintained across these data sources. And one thing to say is that not only are these from different countries and different populations, but they're also from different database types. So we have some electronic health records in there, we have some GP databases in there, and we also have claims databases in there. So what we think is this model is very robust, very transportable, can have a direct impact on clinical practice. One other key thing to note is that we know that calibration is important. So if you have a well-calibrated model, it will have a better clinical impact than a model with similar discriminatory performance, but a worse calibration. Actually, this is one of the new flexible calibration curves that we've just added into the package. If you're interested in this, you can come and see my poster, which is poster 27 in the next section. To conclude, what I would say is that we have very good model performance here. So model performance between sort of high 70s to 90. This is preserved across multiple data sources, and we've also got excellent calibration on here. And so I feel like this study really helps demonstrate the power that the Odyssey community can have in producing these prediction models and giving the confidence to clinicians to actually use these prediction models. And we can do this at a global scale. And I would say that to do sort of 7 of these database validations, it took me 1 day. So that's something to remember when you are running these studies. And the other thing that's nice is that if you are a data stakeholder and you have your data in the OMOP CDM and you want to add a line to the diagram that I have, you can go to this GitHub link, you can download it, and you'll run the best performing model that I created against your own database. So thank you very much for listening to my talk.